So the next presenter is Lawrence Manning. I think he will be presenting online. You will be presenting on subcutaneous antibiotic dosing.
So we're going to go on a whistle-stop tour of subcutaneous antibiotic dosing, which I guess Mark kind of was a good segue from Mark's presentation earlier. I'm mainly going to sort of focus on the beta-lactams and glycopeptides that are used commonly in hospital and in our OPAT settings, but briefly touch on some work that we've been doing related to benzathine penicillin G subcutaneously delivered for syphilis and rheumatic heart disease. So there are lots of reasons why we might think about using subcut antibiotics. For a start, there's a sort of a cohort of patients for whom cannulas, you want to avoid cannulas and or PICC lines and or intramuscular injections. And this might be in people who use drugs, people who have difficult IV access. And I found a really interesting paper the other day that reported that 23% of children needed more than 4 attempts to obtain peripheral venous access. And then more recently, certainly as part of our work, and sort of a response to the renal physicians as a vein preservation strategy in end-stage renal disease. Subcut antibiotics, they might be more, provide some logistical advantages and get people out quicker for patient flow. There's some evidence that it's less painful, certainly, than having a cannula inserted or intramuscular injections. And actually, there might be some PK advantages as well, particularly for those time-dependent antibiotics, where you have a lower Cmax and higher trough concentrations, which could be exploited for alternative dosing regimens. The main sort of downside is the risk of skin necrosis. And this is sort of for people who are working in the field, this is the big fear. And this is pretty uncommon. There are a number of case reports, but they're largely using aminoglycoside. So the majority of the case reports for skin necrosis have been with gent or tobramycin. So based on a whole lot of particularly French data, which had been doing, the French have been using subcut antibiotics for some time now, and both in the geriatrics setting, amongst ID physicians and also general practitioners, there was an emerging body of evidence to suggest that this could be used more broadly in the Australian context. So at Fiona Stanley Hospital, we started using ertapenem, ceftriaxone, and ticaplanin as subcut infusions in certain patients. And we basically use this subcut catheter here. It's a 22-gauge subcut catheter. It's super easy to insert at the doses shown there. And they are administered with 50 mils of normal saline over 30 minutes, usually in the anterior abdominal wall. But we've had some patients where we've administered it in the thigh or the upper arm or the muffin tops on the back. Our experience with ertapenem has been, we've done quite a few patients now. This is a early study from a few years ago, and we've now delivered it probably to 100 patients. Again, you can see that the duration of time on OPAT for subcut ertapenem is the same as IV. So we've been delivering it for 10 or 12 days to treat severe gram-negative infections, for example. There's a higher rate of patients in the subcut group with renal impairment, sort of reflecting this idea about using this as a vein preservation strategy. And you can see down the bottom there that the treatment success and the adverse outcomes are comparable. So they're very promising. So basically, and we've done fewer patients with ceftriaxone and ticaplanin, but that certainly has been done at our hospital without any complications. The one thing to note is that for some reason, ticaplanin seems to be a little bit less well tolerated than ceftriaxone and ertapenem. So we thought, well, there might be some other opportunities for other drugs to be used. And so we've just completed a crossover trial of subcut cefazolin, so where patients got a single dose of IV, and we did a PK profile and then a single dose of subcut cefazolin. This is 2 grams. And this work was done with Jason and the team there, which has been great. And you can see on the graph on the left there, in black, that's what we see with an IV dosing. You can see the dashed line in grey is what we see with the subcut dosing of 2 grams TDS. And you can see that, as expected, you see a lower lower peak and a higher trough. And, this is as we expect. And you can see the probability of target attainment on the right-hand side for the subcut antibiotics is actually better than we'd obtain with the intravenous antibiotics. And sort of based on that, we've also speculated that if we were to use this as either a 3 gram twice daily rather than 2 grams TDS or a subcut infusions, you would get either equivalent or slightly better PK profiles. So these are potential options which could be considered in the future. Similarly, we've done the same thing for meropenem. Again, this is a smaller crossover trial with only 11 participants. And again, you can see that the same PK profiles are demonstrated. And this was with 1 gram 3 times a day. And you can see the probability of target attainment. Sorry, I've changed the colors of the graphs here, but you can see that the subcut dosing is probably slightly better, certainly at the higher MICs than the IV dosing. And if you were to use, instead of using 1 gram TDS and you use 1.5 grams twice daily, you can see you have a similar kind of profile. So that might be considered an advantage. And I guess just to sort of talk a little bit about our body of work in rheumatic heart disease and syphilis, we're now finished or have ongoing phase 2 trials using very high doses of benzathine penicillin, so up to 9 times the standard dose, delivered as a subcut infusion for patients with rheumatic heart disease who ordinarily would have an intramuscular injection given every month. We're now able to deliver that. It hurts less and it lasts longer. So instead of coming in monthly, they can have their secondary prophylaxis for RHD every 10 weeks. So we've now delivered that approximately 200 times in New Zealand for young people, young Māori and Pacifica people with rheumatic heart disease. And we've got an ongoing phase 2 trial of delivering the entire dose for latent syphilis at a single visit rather than having to come in for 3 separate injections a week apart. So that work has been really encouraging for subcut delivery of bicillin. And this is what you see on the ultrasound over time. At day 28, you can see the bicillin sitting as a sort of a depot under the skin. And these are the PK profiles you will see with subcut bicillin relative to intramuscular injections for rheumatic heart disease. You can see that they end up at the same point at about 10 or 12 weeks. And this is what we see for SCIP, or the subcut infusions for syphilis. So we're quite encouraged by these profiles. So the blues for the subcut infusions and the red's what you'd see with 3 intramuscular injections. So this is where we've got to. At the moment, we're doing 1 gram of ertapenem, 1 gram of ceftriaxone, so 800 milligrams of ticaplane, and that's kind of within our standard of care at Fiona Stanley. We just started the trial yesterday looking at a higher dose of ceftriaxone to make sure that that's safe. And I guess just to reflect back a little bit, the subcut cefazole and meropenem are very well tolerated. The pain scores are either 0 or mild pain. So it's very well tolerated by the participants. For cefazole and meropenem, there's obviously a patient group who you'd like to consider using this in. We're planning on trying some different dosing regimens to ensure that they're tolerable. And then finally, for the bicillin, we're going to finish off the phase 2 trials in the coming years, particularly in rural, remote Aboriginal communities. So that's what we're up to. Thanks for your time and listening, and I'll stop there. Thanks.
Thank you very much. Truly a promising approach to antibiotic administration, I think.